Treatment. Surgery is the mainstay of therapy for Mirizzi syndrome, permitting removal of the causal factors, the inflamed gallbladder and the impacted stone. If the diagnosis of Mirizzi syndrome is made preoperatively, an operative strategy that minimizes the risk of injury to the biliary tract can be carried out. ERCP, direct cholangiography, or magnetic resonance cholangiography should be performed in patients with clinical jaundice, serum bilirubin 3.0 mg DL and signs and symptoms suggestive of biliary obstruction. Intraoperative cholangiography is frequently employed to clarify the biliary anatomy at the time of surgery. A standardized surgical approach has been recommended based on the classification of the variants of Mirizzi syndrome. Type I, partial or total cholecystectomy, either laparoscopic or open. Common bile duct exploration is typically not required. Type II. Cholecystectomy plus closure of the fistula, either by suture repair with absorbable material, T-tube placement, or cholecystectomy with the remnant gallbladder. Type III cholecystectomy or bilioenterocanastomosis choledochoduodenostomy, cholecystoduodenostomy, or choledochoduodenostomy, is required, depending on the size of the fistula. Suture of the fistula is not indicated. Type IV bilioenterocanastomosis, typically choledochoduodenostomy, is preferred because the entire wall of the common bile duct has been destroyed. The approach may vary with the type of fistula present. Both the operative mortality and postoperative morbidity increase according to the severity of the lesion. Laparoscopic surgery. Mirizzi syndrome presents a difficult challenge for laparoscopic surgery because the dense adhesions and edematous inflammatory tissue cause distortion of the normal anatomy and increase the risk for biliary injury. Thus, the use of laparoscopic surgery as the primary treatment of Mirizzi syndrome is controversial, although it has been reported for patients with type I and type II anatomy. A systematic review of 10 case series reported that laparoscopic cholecystectomy was successful for 73 of 124 patients, 59% with Mirizzi syndrome. In a retrospective series of 35 patients who had surgery for Mirizzi syndrome, laparoscopic surgery was attempted in 15 patients and the conversion rate to open surgery was 67%. Although laparoscopic surgery may be possible in some patients with type I anatomy, open cholecystectomy remains the standard of care for Mirizzi syndrome. If a laparoscopic approach appears feasible, a prudent policy is to begin the dissection laparoscopically and convert to an open procedure if the anatomy is unclear. Endoscopic therapy. Endoscopic treatment can be effective as a temporizing measure before surgery and can be definitive treatment for unsuitable surgical candidates. Endoscopic removal of common bile duct stones also avoids the need for common bile duct exploration at the time of surgery. However, endoscopic approaches can be technically challenging, are not always successful, and have been associated with complications. Long-term success appears to be most likely in patients with type II disease who do not have residual gallbladder stones. The following illustrates experience in the largest reports. One report described the experience with 14 patients with Mirizzi syndrome treated with electrohydraulic lithotripsy. 12 patients had a single stone and complete clearance was achieved with one treatment session. 2 had multiple ST1s and required an additional treatment session. Asymptomatic leakage of contrast medium from the cystic duct into the peritoneal cavity was observed in one patient after removal of a large impacted cystic duct stone. This patient recovered with conservative therapy and suffered no adverse events. In another series of 25 patients with cholangiographic evidence of Mirizzi syndrome, 12 were referred for surgery after preliminary endoscopic therapy and 13 were treated solely with endoscopy. The endoscopic approach included sphincterotomy, mechanical lithotripsy, dissolution therapy with methyl tert-butyl ether, extracorporeal shockwave lithotripsy, and common bile duct stents. Complete clearance of stones from the biliary tree was achieved in only 3 of 13 patients while 9 patients were treated with long-term stenting. 5 patients died, including 2 who died of biliary causes. Association with gallbladder cancer. The Mirizzi syndrome has been associated with a high frequency of gallbladder cancer. In one series of 1759 cholecystectomies, 18 cases of Mirizzi syndrome were identified. 28% had coincidental gallbladder carcinoma versus only 2% in the patients without Mirizzi syndrome. The patients with and without gallbladder carcinoma were comparable in age, gender, type of lesions, and the duration of jaundice. The patients with gallbladder carcinoma had a longer history of pre-existent gallbladder disease, 10.4 versus 6.8 years in those without carcinoma. The serum concentration of the tumor-associated antigen CA19-9 was elevated in 12 of the 18 patients with Mirizzi syndrome, but was significantly higher in those with malignancy, peaking at 1000 unit milliliter. The authors suggested that it is prudent to obtain an intraoperative frozen section of the gallbladder in patients with Mirizzi syndrome. In another report, Mirizzi syndrome was present in 133 patients out of a total of 4,803% who underwent cholecystectomy. Of the 133 patients, 75% had gallbladder cancer compared with only 1% in those with gallstone disease without Mirizzi syndrome. Of the 7 patients, the gallbladder cancer was detected preoperatively in 1, intraoperatively in 1, and on pathologic examination of the gallbladder in the remaining 5. Although gallbladder carcinoma may be common in patients with Mirizzi syndrome, the latter disorder is unusual among patients with gallbladder carcinoma. In one series of 324 cases of gallbladder carcinoma, for example, 18 had common bile duct stones but only 3 had Mirizzi syndrome. Summary and recommendations. The Mirizzi syndrome refers to common hepatic duct obstruction caused by an extrinsic compression from an impacted stone in the cystic duct. The Mirizzi syndrome is part of the differential diagnosis of obstructive jaundice. Most patients present with the clinical triad of jaundice, fever, and right upper quadrant pain. The major laboratory findings are elevations in the serum concentrations of alkaline phosphatase and bilirubin in over 90% of patients. The diagnostic approach usually begins with ultrasonography followed by cholangiography via endoscopic retrograde cholangiopancreatography, direct percutaneous cholangiography, or magnetic resonance cholangiography. Surgery is the mainstay of therapy for Mirizzi syndrome, permitting removal of the causal factors, the inflamed gallbladder and the impacted stone. Although laparoscopic surgery may be possible in some patients with type I anatomy, open cholecystectomy remains the standard of care for Mirizzi syndrome with compression of the common duct. For patients with a fistula, or erosion into the common duct, the choice of repair depends on the extent of the damage to the common duct. Endoscopic treatment with or without electrohydraulic lithotripsy (EHL) can be effective as a temporizing measure before surgery and can be definitive treatment for poor surgical candidates. The Mirizzi syndrome has been associated with a high frequency of gallbladder cancer. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Atef Ahmed wishes.